is really important. Don't think I'm too young. It's really in your early 40s where majority of the symptoms start. If you are not feeling yourself, you are not sleeping anymore, having very low sex drive, maybe painful sex, you are feeling very anxious or depressed, and it never was you before, there is a very good chance that might be hormone related.
Hello, everyone. I'm your host, Dr. Shafer of Talks with Dr. Shafer. I'm a physician, mom, life coach, musician, author, publisher, and I am passionate about using storytelling as a tool to help you reclaim your story and build your most beautiful future. Today, I am so excited to have a fellow physician as a special guest on the show. Dr. Roberta Corona is an OBGYN and the medical director of the BioConnect Medical Center in St. Michael, Barbados. Dr. Roberta Corona is spreading the word about menopause and how women can navigate this period of life with the help of modern medical treatments such as HRT. I am so grateful that Dr. Roberta Corona is here to share her wisdom with us and her story. And I also would really love if she could also share some of the heat that they have down there in Barbados, because currently I'm up in northern Michigan and we don't have heat after the ice storm. I'm surrounded by a space heater and I'm sitting on my heating pad, just trying to keep from shaking here. So please, Dr. Corona, bring some of your heat and warmth to us as well. Thank you so much for being here again. And I am so excited, Dr. Corona, to hear about your story, what inspired you to go into medicine, and also to be really publicly speaking, even outside of the confines of the clinic, to share this important message of how women can best navigate menopause.
This is a very dear topic for me. There is so much need to spread this information. I feel like women have been robbed of this information and the quality of life at the end of the day. We spend almost half of our life in menopause and we don't know anything about it. And even myself, I have to be very honest, as a physician, obstetrician, gynecologist, I started learning about menopause maybe 10 years ago because it was my choice. And then when I decided, oh my God, we don't know anything about it. I was working in fertility mostly, and I realized that lots of my patients, on everywhere in the world, they were in their 40s really, trying to have babies. And majority of these women were actually perimenopause and started to have these symptoms, and they didn't have a clue, and neither myself, honestly. So I said, okay, no, I cannot. I cannot serve my women if I don't know what's going on. So I started studying, educating myself, and realizing that really we don't teach was a medical school. So that's another thing I'm trying to do. Is for the first time actually at the university here, we are introducing courses a little bit more specific about menopause, how to treat patients. And it's not only a matter of women and a niche, because doing menopause care, it's really doing women care, is doing medicine, because it really impacts every single function of our body, from the cardiovascular system to your brain, to your bones, your muscles, your gastrointestinal system, your skin, your oral health, even your eyes, your vision. So it's not a guy thing. All GP should know about it, because I have horrible horror stories of women going to the GP because they don't feel like themselves. They are desperate. They are depressed, or they are having suddenly, palpitations, and they feel they are going to have a heart attack and they are dying, or they have memory issue and they're feeling, oh my God, I'm having dementia. They really don't know what to do. They don't know where to ask for help. And then they go to the doctors, and in most of the case, they are misdiagnosed, they are gaslighted, they're not listened, and because they don't know, they really, even the doctors don't know. That's not an excuse, though. I think it's, as a physician, it's our responsibility to keep updating our knowledge, to keep studying, to keep educating ourselves. And still too many times I hear my colleagues say that because I, I, I don't agree with it. I don't believe in it. It's dangerous. And medicine is not a belief. I mean, it's not like believing in Santa. It's science. It's not magic. So if you don't know, you should be able to say, okay, wait a moment. I'm not knowledgeable enough about it. I refer you to a menopause specialist, or let me read a little about that. Let me read the latest scientific evidence on this, and then I get back to you. That's how it should always be, and it's not, unfortunately. So we are here fighting against a wall of ignorance. That's the right word, really. And this opportunity, this talk, this podcast, and there is a lot going on now, luckily, finally. It's a way to break that wall and to get out some of this knowledge. Is it the best channel? I don't know. Yes, it's a channel. It should not be the only one, though. So I really hope that more and more physicians will get interested in this field, because at the end of the day, that's what we want: is that our patients feel good and don't just survive. And that's what's happening, really.
Exactly. You bring up so many important points as to why this message is so incredibly valuable to share with people, and also why it does require this really intentional approach. It's interesting because right now in the United States, there's a lot of talk about inclusion of women's health, right? Is something I'm sure is in the news worldwide. And sometimes when we talk a lot about something, especially as women, we can get some pushback. We experience pushback of, gosh, why all this talk about menopause? It's enough already. But the reason we're doing it is because it's not enough, and it's not a part of the standard educational experience of medical school. And those of us who have gone through medical school, we know that, yes, there were a few slides about the hormonal changes of menopause. There were a few slides in a few classes as we were going through our training. And as we went through.
When WHI came out, I was in my early years of residency. And I remember like the huge impact of this. We didn't know what to do, really. I still remember exactly the day I was in the office with some of my colleagues and my professor, and we said, "Oh my God, what do we do? We need to let them stop." But we didn't have actually the paper to read, so we really didn't know the stats. And my professor, that was actually a menopause specialist, when I was doing the fellowship in something completely different, in laparoscopy, he said, "Oh, that cannot be true. That cannot be true. I don't. I want to see the data. I don't think this is right." And that was, for me, something stayed there, and I kept looking into it, and indeed, it didn't make sense. It really didn't make sense, because when we got the data, statistically, it was not significant. It was almost significant. It doesn't mean anything in medicine. And then you keep looking, and they compare apple to pears, and again, wait a second. They include women that are not really our ideal candidate for therapy. And also, we are 25 years from there now. 25 years is huge in science. It's incredible. And what you said, I get this all the time. What's all about menopause suddenly? We all went through that. My mom went through that. My grandma went through that, and they didn't have any problem. And why is so trendy suddenly? Okay, so I would like to answer to that. I don't believe that your grandma or your mom didn't have any problem. That's absolutely a lie.
Hmm.
Probably they didn't even know was menopause. That's the problem. Because when I ask a little bit more questions, but are you sure your mom didn't have this? Maybe she had osteoporosis. Maybe she had incontinence. Maybe she was, going a little bit off, very irritable on those days when you were a teenager. I said, oh yeah, indeed. Actually, she had like UTIs all the time. They didn't know what to do. I didn't know that was menopause related. And this is actually why we call this clinic BioConnect. That's a little bit of a curiosity. Because what I realized, me and also my co-founder, my friend and business partner, we noticed that women were not able to connect those dots, to connect those symptoms. Many times patients said, okay, I'm done with menopause. It was like 5, 6 years ago. What's going on now? That cannot be related to that. And unfortunately, lots of menopause symptoms, or I would say more menopause complications, are long-term effect that we see 10, 15, 20 years after the last menstrual period. And these are complications because they are things that could possibly be prevented. I'm talking about osteoporosis. I'm talking about weight gain and consequently metabolic disorder like diabetes type 2, high blood pressure, depression, anxiety, being on medication for that, and even dementia in a way can be related to menopause changes. So there are so many long-term effects that we didn't know probably were related to it. We are living so much longer now. We have a different concept of quality of life. We are much more aware of that. I mean, I as a 46 years old woman and perimenopausal, I am very much different of my mom or my grandma. We we work, we have positions, even very important positions that probably 20, 30 years ago we didn't have. And even if we don't want, we have to work much longer because I don't even know if we're going to get a pension with things, how things are going. So it's a right to be able to work, and it's also a necessity, unfortunately, for many of us. We have kids much later, so we have younger kids. I have a 6-year-old, and I'm perimenopausal. So I really cannot afford to stay in a room, close the door, and okay, I don't want to see anyone. I don't want to talk to anyone. That again should not be how life is. But this is it. We don't have the luxury to like let go, even if we wanted. And we don't want. I don't want to let go. I want to lead. That's my call. But I cannot do that if I'm not sleeping at night. I wake up in the morning and I'm completely fatigued, in pain. I just don't have the drive to do anything. And because I'm in pain and I feel fatigue, probably I'm not gonna exercise anymore. I'm not gonna pay too much attention on my diet. Yes, lifestyle is proven to be important. It's the most important thing we can manage and control for our quality of life, for longevity. But you cannot have a great lifestyle if you are not in a good place. So when I hear this patient coming to me, or my daughter just told me, you know, you need to lose weight, you need to go to the gym, and that's it. I feel so bad because it's in many cases it's really not their fault. They just don't have the power to get there. So maybe they just need that help, the push, so they can make those changes that yes are important, of course, more than a magic pill. There is no magic pill, but we cannot get to that point if we don't explain them what's happening in their body, why this is happening, how can we manage that? And it can be a chutney, it can be not a chutney, it can be so many other things. But education, knowledge, comprehension of what is happening, that's the first step to make a change.
Yeah, I really appreciate how throughout our conversation you have mentioned a lot of the symptoms that people may be experiencing when they're going through perimenopause and menopause, and highlighting also, and I want to say it directly, the importance of when we're having these symptoms, making sure that we're reaching out to sources that can help us navigate those who are educated in perimenopause and menopause. So again, another reason to get this message out and be very clear about why we're doing so is that so many people, half of the population, are going to experience at least some of these symptoms at some point in their life because of the biological certainty of menopause if you get to a certain age, if you live that long. And so being able to navigate them and not be essentially gaslit by the medical profession inadvertently because of a lack of understanding on their part, because of a lack of education and having it really programmed into the experience and understanding that, you know, you are in part, not only are you a highly educated expert in your field of obstetrics and gynecology, but you're also a woman and you've experienced that. And that life experience has also informed you of how you practice, and understanding that we as doctors need to make sure we're educating everyone, including our wonderful male counterparts who won't have that lived experience or maybe won't have had those conversations openly with their mothers or their grandmothers. So they don't have the life experience. So we need to get really serious about educating about menopause. Yeah, because
Yes.
exactly.
We want to do
Yeah.
a webinar just when we were talking about that. I said, wait a second. It's not that I want to give them a free pass. Okay, I don't want to say, "Oh, poor you, you're living with a perimenopausal women," because they also should have a proactive approach and try to understand what's happening and be supportive. That's very important. If your partner is not supportive, there is something wrong with your relation. Nevertheless, it's difficult for them if they don't know. It's like for us, right? So I really encourage my patient to come with their partner if they can for the first consultation at least, because we have this chat. We explain what's happening in the body, and you see immediately they say, "Oh my God, really? You go through all of that?" They don't have a clue. They don't have periods. We kind of, have an idea of those fluctuations every single month. And they do have an idea, okay, well, okay, she's getting her period, maybe she's a little bit more moody. Uh, it's not funny, really, but that's really that's all about the no. That's it. Okay, it's close to the period. Maybe they are getting, that's the reason, right? Now imagine, let me go a little bit back now and explain what's perimenopause and menopause, what's happening in the body. And I'm going to try to make it very, very, very simple. So, women are born with definitive number of eggs, okay? We actually have lost already many even before we are born. And we keep losing them until puberty. We have lost almost 2/3 of those eggs that we had when we were born. And then every single month after the puberty, to get one of those eggs mature, we use hundreds, we lose hundreds. Plus, there is pollution, environmental factors, chemicals, medications, that some disease, autoimmune disorders, surgeries, so many other factors can also affect that number. But definitely, unfortunately, we do not have a key yet to bring time back or to create new eggs. That's something hopefully in the future we will have, and we are working on that. But for now, when we get to our early 40s, really, we get to a point where we really have a low number of eggs available. So because we reach that point of a very low level, our ovaries are starting to be dysfunctional. They are not responding as good as they should. So the brain, the pituitary gland in the brain, every month produces an hormone that is called FSH, or follicle stimulating hormone. And it does exactly what it says. Okay? It stimulates the ovary to get the follicles, that are the little cysts that contain the eggs, to grow and to bring one to maturation. Okay? So if the ovaries do not have a good reserve anymore, it kind of take longer to respond. Imagine if they cut work force. I think that's a good analogy
Yeah.
right now
Hmm.
in the States.
Hmm.
And you still have the same amount of work to deal with. So what's the result? The result that you got everything get delayed, right? You're gonna need to wait much longer before getting something done. So the pituitary gland is not getting a response, so it start raising voice, okay, until it starts shouting, and that FSH is gonna go really high, and your ovaries are finally not responding anymore because they don't have any reserve left. So when this happens, that's what we call postmenopause. No eggs anymore, no response anymore, FSH is high, and obviously the estrogen and the progesterone are basically non-existent anymore. But what's happening in the transition is the perimenopause, is where yes, there are still some eggs, and they're trying to respond to get there, but the response is not as good as should be. So there might be suddenly everyone start working on the same thing together, and boom, the estrogen go really, really high, and you have actually hyperestrogenism symptoms, and then suddenly everything drops. No one is responding anymore. And you might have few months where you don't get your periods anymore and nothing is happening. Your level of estrogen and progesterone are really low. And then again, it goes up. It's like a roller coaster. So
Mm.
we have at the same time symptoms of too much estrogen, too little, too much progesterone, too little. What these results? What's the result in your body? What are you experiencing during this time? Everything? Nothing. So there might be a couple of months where you have all the possible symptoms. There are more than 100 symptoms really. Or finally, oh, I'm feeling good again. Maybe it
Mm.
was just, it was something else. Maybe I got, I had a flu and my body was just getting rid of a virus. And you are great for a few months, and then boom, again, you precipitate. There are receptors for estrogen in every single cell of our body, and we need it. We really need it to function. So if suddenly it's taken off of us, it's not that our body adjusts in one day. It's impossible, really, physiologically impossible. And there are so many functions of our body that are regulated by estrogen. We will survive without Yes, we probably will. The body, a human body is amazing. We'll find a way to go around that, but not as good as it was doing before. And with, unfortunately, some complication due to that.
Hmm.
There are even receptors for estrogen in the bacteria in our gut. Can you imagine that?
Yeah, that's amazing. And so that's going to have yet another connection to your health. And we talk a lot about
Exactly.
gut health
Yeah.
and how the biome is affected by our environment. And so I think that's a really interesting thing to bring up. So here is someone who is in perimenopause, they're having fluctuations in their estrogen levels that they're having to navigate on a daily basis or on a monthly basis. They're having these symptoms they don't have an explanation for. I think it's important to also bring up that as they are reaching out and getting support and hearing about, okay, what can I do beyond things you talked about earlier, which is lifestyle, right? You know, tell me to sleep better, tell me to eat better and exercise and have good, healthy relationships and support in my life. Yes, I will try to do those things. But when they're thinking, what can I do next to get me through? Because I'm trying, but in the face of these, it's not working in the face of these hormonal imbalances. I need assistance and help. I think there is some fear about the next step, about taking therapies to help. And a lot of that may be based on things that maybe they read in the papers about hormonal treatments and potential side effects, or potentially things that have been shared with them by their family and friends. And as you said before, you know, well, mom and grandma went through it without that. So do I really need that? What's the big push now? So could you share with us what you would share with a patient who came in and they were feeling hesitant, but wanting to learn more about HRT and other ways beyond lifestyle modification to help them navigate this time?
Yeah. Is the key word here. I did a huge the big one is the breast cancer. I'm going to talk about that in a moment. I have to say it's also because of the cultural thing. Uh, we are educated to really power through everything, being resilient, not complaining, right? And so even we feel like a failure if we ask for help and we take the medication. It's like, no, I don't want to. I can't do it without. And my question is, why? I mean, it's a concept of insanity, really. If you have a solution that is there, is safe, why would you want to suffer? It's like going through a, procedure without anesthetic. Why would you do that, right? You would not. And still, there are women that go to labor without taking any anesthetic because, again, culturally, there is this thing about maybe you are a better mother if you suffer through it. And it's not. Your son or your daughter will not know whether you have used it or not. They will not love you less, and you don't get a medal for that. Okay, there are no points, not at all. Okay, but the fear is that okay, something dangerous for me, so I don't want to take a medication. Is the only endocrinologic disorder, because that's what it is deficit of two of the main hormones that we have produced for all our life, and suddenly they're not there anymore. No one has a minimal hesitation to take a thyroid medication when your thyroid is starting not working properly anymore. And you know what? You will survive without probably, but you will not feel really good. Uh, and immediately, thyroid is not working. Great, take this pill and nothing happens about that menopause. Again, yes, it's a natural stage of life, like his aging, like his erectile dysfunction, but If a man goes to the doctor and say, well, I'm having a problem with erection, boom, they get a pill without even too much discussion about it. And the side effect complication of those medications are much worse than any possible side effect complication than HRT. So HRT means hormone replacement therapy. And I don't love it. We're trying to change it with menopause hormone treatment because really it's not a replacement. I would say it's more a supplementation because we don't want to give you all that amount of estrogen that you were producing when you were in your 20s or your 30s. We really don't need that anymore. We don't want to have kids anymore. We just want to function. And we want you to have just enough for your body to function. I would say there are three main goals. One is the symptom resolution, one is the preservation of function, and one is prevention of some long-term disease. So three main goals that not many other treatment can actually achieve so much.
Yes.
Every single study, even that horrible WHI that was done by then, actually shows that women using HRT live longer. HRT decrease mortality for all causes. Women die mostly of cardiovascular disease, more than all cancer together, not let alone breast cancer altogether. So this really, when we look at longevity, quality of life, and health, this should be one of the main goals for us, trying to prevent and decrease those causes of mortality. In terms of breast cancer, again, if we look at the WHI, there were a few biases there, many, but let me tell you the most important. One was that women included in the study were much older than the women are the ideal candidate. Many were even smokers. You will not believe that. Or they were smokers in the past. Several were overweight or obese. And we know that obesity is actually one of the major risk factors for breast cancer. So again, if we are able to possibly even prevent or manage better your weight, your cardiovascular risk, at the end of the day, you are even decreasing your risk of cancer, and not only breast cancer, but all cancers. But if you want to be, I want to be that really heavy advocate and look strictly at the numbers, using the kind of HRT that was used 20 years ago, that is using synthetic hormones that we don't use anymore. And I tell you the difference in a moment. But even looking at those data, there were 3 extra cases of breast cancer in 1,000 women in 5 years. So women have 1 in 7 women regardless of what you do. If we take all population, we put everyone in a bucket, that's the statistic. Yes, it's unfortunately a cancer for women. Everyone has a chance to breast cancer. If you use that kind of HRT was using that and combined estrogen, synthetic estrogen, there were few extra cases, and it was not significant. And when you adjust for many other factors, we realize that actually the medication we use now, we have made such a huge. They are mostly what we call body identical hormones or bioidentical. They're really the same thing, it's just different marketing way to put them. And what it means, body identical, is that the molecule that we use is exactly the same that the one we produce naturally. So let me give you a little example. It's like a hormone is a messenger, it's like a key, and it's gonna open a specific locker. Okay, that when it opened, it open a door in the cell and give a message to produce something, to stop producing something, to produce more, whatever is the message. Okay, so it's a key and it's a locker. It's a lock. So a body identical hormone is like your original key. We all have experienced probably having redone some keys or cut more keys because we need more for the same one. And we all know it doesn't really work as good as the original. Never, right? It kind of needs, you need to kind of play a little bit there. Sometimes it happens immediately, sometimes it doesn't, sometimes it breaks and doesn't work anymore. So that's exactly what's going on with a body identical and a synthetic hormone. So the body identical, poof, goes smooth, no effort whatsoever. And because it's the one we produce, there are really, I would say, no side effect or minimal. A synthetic one obviously might have more implication. Sometimes we need a synthetic one. I'm not saying they are necessarily bad because we might need a more powerful hormone or we might need a hormone that works only on some specific areas and not on others. So synthetic hormones are amazing in some way, but in terms of HRT, because we want to be as natural as possible, we want to, we really don't want to create super women. We just want to give you back what you are missing. So we use a natural form that is extremely safe because of that. There is not one study in the literature that shows any bad effect of a body identical estrogen. No one. None. Zero.
Well, that is really helpful information for our listeners who may be concerned or have fears because as you said, and as I've experienced in conversations with people, just in my casual conversations and in clinic, there is fear about hormones. I mean, we were raised, years ago, talk about steroids, for example, and talk about testosterone and what that became in the media and in conversation was something really scary and all these negative side effects. And so I think a lot of times people take the information from those old conversations and they lay them on these new conversations and think that they have similar side effects or risks. And what you're telling us and sharing with us is that it's simply not the case. And there's actually some legitimate concern and risk to avoiding having this conversation with your physician who is informed and has these tools to share with you. It's a personal choice and a decision that you have to make based on the information, but make sure you're getting good, accurate information and also try to allay those fears so that you are coming to this decision from an informed place and not a place of fear and not a place that is worried about things that the literature and science have disproven, or maybe this was a problem before, but because we
Yeah.
have different, better tools, it's no longer the issue that it once was.
The message is this: every woman has the right to have the conversation. We are not, we are able to take decision for ourselves when we are educated. And unfortunately, again, this is something very misogynist in medicine. While male are given always the choice, okay, that's your risk. You decide you want to take it or not. We women is not, no, I don't believe in it, so I don't give it to you. Wait a second. I mean, even if there was a risk, that should be my decision, right? And there are obviously always pros and cons, but every one of us has different priorities and different lives and different needs. So we should be able to get the information, understand the information. So the physician should explain to you those information in a simple way, and then we should have the right to choose for ourselves. I don't
Mm.
believe that everyone needs to be on HRT, and I don't believe that if you are not on it, you're going to die miserable. I do not believe if you are on HRT, you're going to be young forever, you're not having any disease. That's not true neither. And I choose everything. But I see every single day how much better, in most of the cases, my patients are on it. And I can do back to you that I can tell you when I see a woman come in my door 70 years old if she's on HRT or not.
Mm.
Every single time.
I think this has been so helpful for listeners to get this perspective. And I so appreciate you sharing your wisdom. Could you, looking back at our conversation and at your life and helping so many women, are there 3 things that if you could just tell every single midlife woman who is perimenopausal or menopausal and experiencing some or all of the side effects of that stage of life, are there 3 things that you wish you could tell everyone to help them feel heard, seen, and hopeful? Absolutely.
One thing important. Perimenopause can start about 10 years before your last menstrual period. That's key. So you might have still a perfectly regular period, clockwise 28 days, doesn't mean you are not in perimenopause or you are too young. If normal age for menopause is between 45 and 55, depending on many things, it means you could start having symptoms of perimenopause as early as 35. And I'm talking just natural spontaneous menopause. Obviously, there are cases where it can be much earlier. But this is really important. Don't think, oh, I'm too young, because it's really in your early 40s where majority of the symptoms start. If you are not feeling yourself anymore and you are not sleeping anymore, you are having very low sex drive, maybe painful sex, you're feeling very anxious or depressed, and it never was you before, there is a very good chance that might be hormone related. So don't just stop on taking an antidepressant or thinks you are going mad and you cannot cope with your life anymore. You don't love your partner anymore. That's why you don't want to have sex. Don't do that to yourself, to your children, to your relation, because it could very much be that you need a little bit of help managing your hormones. And when I say a little bit of help, sometimes it's really a little bit. You don't necessarily need to take HRT. We might just understand what's happening and guide you and be very flexible, maybe add some supplements, maybe add some little extra things here and there. It can really be done. And that's the most important time of your life, to understand what's happening in your body and to start making those changes to avoid to have issues later on. I see all the time my patients that I've seen them for many years, always very healthy, fit, super good diet, normal weight. And then suddenly they come and their cholesterol is going up, their vitamin D is down, their sugars are going up and down. And that's a sign, one of the first signs your metabolism is starting to change, but you cannot know unless you're really checking your health. So I think probably 40 years old is the time that you need to start being more aware of your health and proactive and do preventative medicine. So even if you don't have any symptom at all, go to your gynecologist and have a chat and have an annual checkup, even if you're not having kids anymore. It's not just for your pap smear, it's really to be on top of your health. It's such a pivot moment of your life. You can make so much of it if you know at that stage what to do. I think that's my main message, really.
Education is so powerful. And I think sometimes when you are thinking of going to the doctor because you're having these symptoms and these challenges, it's really normal to have fears and feel fearful of engaging with the medical profession. But it's important to understand that the root of doctoring is actually to be a teacher,
Yeah,
not to be a dictator or a decider. It is truly to be a doctor. The root of the word is to be a teacher. And so I am so grateful to have you on the show today to do just that, to be a teacher about this very normal and inevitable part of life for women, so that they better understand and are armed with the knowledge so that they can make decisions that will best help them navigate this time in life. Thank you so much, Dr. Corona.
thank you. Let's and let's go through all the details, but that's really not the topic of this. You go to your physician to have the details and check your symptoms that can be so different for all of us. It's really my message again. If you don't feel yourself anymore, if you see things are changing, you don't have to do it alone.
Exactly. You are the expert in your health, and then reach out to the resources,
Yes.
the right resources in your community. No one is asking you to be an expert in
No.
menopause. We are empowering you to embrace that you are the expert in yourself, and not to just go along with, oh, it's okay, just deal with it. No, you can have help, and you can improve. You can reach out for these resources. And if nothing else, just be better armed with the knowledge and understanding of what you're going through, because that can make a big difference in how you feel about your life and your health to start with, and then helps you make better decisions moving forward with the help of your physician and your healthcare team. So thank you, Dr. Corona. How can listeners reach out to you, learn more about the important work you're doing and the BioConnect Medical Center?
No, on our website, BioConnect Medical, full of resources and education there. And you will find our email, care@bioconnectmedical.com. You can reach out anytime. We do telemedicine as well, everywhere in the world, really. And so if you want to have a conversation, we are here. If you want just trying to look into the website and find the resources, you will find that. We also have several events. We do webinars, we do in-person events. We have one coming, actually, I'm going to invite you on that, about menopause below the belt. So we're going to talk about genitourinary syndrome, the menopause. Again, a giant in the room, not an elephant, is a giant in the room. No one's talked about it, no one's not too much about that. The huge changes happening down there, so really, really important. And there are many more topics, really. I hope we can have the opportunity to go through those in detail. So just go on our website, write an email, and we will get back to you if you want.
Thank you, Dr. Corona. Yes, this is just an icebreaker. It's just the start of a conversation that deserves so much more time and attention and ongoing research and just a place in your life and awareness. So thank you so much for spreading awareness of perimenopause and menopause. And thank you so much to our storytellers for being here for another guest episode. Please subscribe to the show so that you are here for upcoming episodes with other inspiring guests of people who are helping to improve your health and helping inspire you to reclaim your story and build your most beautiful future. And join us as we resume, starting in May, our Mindset Mastery Thursday Short Talks on Talks with Dr. Shafer. As always, until next time, stay safe and take care. I'll talk to you soon.